Good afternoon, everybody. I'm just waiting on the ability to share my screen. And we'll get started shortly. Everybody see the presentation? Okay, we'll get started. Again, my name's Eric Snowden. I'm happy to talk with you guys today about an important and underappreciated topic that is Alpha-1 antitrypsin deficiency. And I want to extend special thanks to Dr. Godfrey with her help in finding great resources and in preparation for this presentation. Hold on one second. I'm going to try to get it so it's not showing my notes. Is that better now? Is it just showing my screen? Hold on one second. Okay, here we go. So here we go again. Sorry about that. So I have no disclosures today. Here's an outline of today's talk. We'll talk about a brief history of Alpha-1 antitrypsin deficiency. We'll go over the epidemiology of Alpha-1 antitrypsin deficiency, the physiology of Alpha-1 antitrypsin, and the pathophysiology of the deficiency state. We'll go over the clinical features of individuals with AAT, the natural history of AAT deficiency, and the diagnosis of AAT deficiency, and then we'll finish up with the treatment of AAT deficiency. So throughout this presentation, I'll be invoking information from various sources, including the NHLBI registry of patients with Alpha-1. It was a multi-center study that followed AAT patients for 7 years in order to characterize the clinical and laboratory course of severe AAT deficiency, whether or not the patient was receiving augmentation therapy. I just want to preface this that it wasn't a randomized trial, but an observational cohort study, and we'll go through the study in depth. I also invoke the findings from this document, which is a guideline document that was published in 2003 by the American Thoracic Society and European Respiratory Society. It's an evidence-based systematic review of the current literature regarding the management of individuals with Alpha-1 antitrypsin deficiency. So we'll go over the history first. The history of Alpha-1 antitrypsin deficiency dates to 1963 when the gentleman on the left, Carl Laurel, who was a senior protein chemist, and Sten Eriksson, who was a medical student at the time in a Malmö lab in Sweden. The Malmö lab, I found out that is a very famous lab. Waldenström's macroglobulinemia was described years before at this lab. So Carl Laurel was doing some quality control study. He was observing SPEPS patterns in 1,500 patients. And he noticed that 5 of the specimens lacked protein in the Alpha-1 region of the SPEP. He then turned to Sten Eriksson, who was a medical resident at the time, like I said, who was following a number of these patients in his continuity clinic. He noticed that several of these patients had emphysema at an early onset, and some of them had a family history of emphysema. So it was chance collaboration with a senior scientist and a medical resident that came to the observation and first description now 59 years ago in 1963 of Alpha-1 antitrypsin, which is characterized by a deficiency of the protein in the Alpha-1 region, known to be Alpha-1 antitrypsin, accompanied by clinical manifestations of emphysema, usually of early onset, that was familial. And since 1963, there has been an explosion of information on Alpha-1. So we'll go over the epidemiology of Alpha-1 antitrypsin. So although I've never seen an Alpha-1 antitrypsin deficient patient in clinic or in residency in my short time in fellowship, after completing this presentation, I think I've probably seen Alpha-1 patient and probably misdiagnosed the patient or just thought that they had asthma or COPD. So there's 24 million Americans with COPD, and roughly 3 million or so have emphysema. Lieberman did a study where he sampled 965 veterans at the COPD clinic at a VA hospital, and he found that 3% of the individuals had severe PI-ZZ type, which is the most common severe deficient type and the most common allelic deficient combination type. I will speak on the nomenclature a little bit later in the lecture. So 3% of 3 million leaves us with an estimated US prevalence of patients with lung-affected AAT deficiency to be around 100,000, with the number of diagnosed Alpha-1 antitrypsin deficiency being, some studies say 15,000, some say 10,000. So the estimated US prevalence is 100,000 with a number of diagnoses less than 15,000, just goes to show how we are missing this diagnosis. This is a nice schematic of the prevalence of Alpha-1 in the US. Uh-oh, it's PowerPoint just shut off. Hold on one second. Are you guys able to see the presentation?
Yes.
You can see it? Okay. So back to the presentation. So Alpha-1 is more common than previously thought. You can see that IPF carries a prevalence of around 130,000. Alpha-1, like I said earlier, around 100,000, and very similar to sickle cell disease. And then you can see other lung diseases like cystic fibrosis. I don't know what's going on. Sorry, my PowerPoint just keeps shutting down. Okay, sorry about that. I don't know what's going on with my computer. Can you guys see it again?
Yeah, we can see it. We were all admiring your beard in the interim.
Oh, thank you.
This is Vashti. It's Vashti.
Okay, so more direct population-based studies, based screening also provide these epidemiologic estimates on the frequency of Alpha-1 antitrypsin deficiency. There are two landmark large studies. The first one being by O'Brien in 1978 in Oregon, where they did heel stick bloods, and they estimated the frequency of severe deficiency in newborns to be 1 in 5,000 newborns. There was later a study by Sveger in Sweden, which was similar to O'Brien, and he showed the prevalence of severe disease to be 1 in 1,500. The severe allele type being the PiZZ, which is more common in Scandinavia, where it's believed that the PiZ gene originated. You combine these studies, you come up with a 1 in 3,500 incidence. So you extrapolate that to a US population of about 330 million. That leaves the concordant estimate of around 100,000 individuals with Alpha-1 antitrypsin deficiency. So where are all these individuals? I wondered the same question, like, how are we missing them? Where are they in the population? Silverman did a study in St. Louis where he went to the St. Louis Blood Bank and sampled 20,000 blood donors. They reasoned that Alpha-1 antitrypsin deficient patients did not favor a bias against blood donation, which I think is a reasonable thought. Of the 20,000 blood donors in St. Louis, they found that 7 PiZZ individuals were identified, which showed the prevalence to be 1 in 2,900 patients, which agrees with the data from the newborn screening studies from the previous slides. So what they did is in the St. Louis community, they called all of the pulmonary, GI, and allergy physicians in the St. Louis area and asked them, how many patients do you follow with AAT deficiency? As you can see, only 28 PiZ individuals, leading to about 4% that were clinically recognized by the physicians that they surveyed. This led to the conclusion that supported that, along with other pieces of data, the major message that Alpha-1 antitrypsin deficiency is highly underrecognized, and therefore it is important for us to recognize this, as recognition of this condition has both genetic implications to the family and therapeutic implications for the patient in front of you in your office. So the concept has emerged of the iceberg, and the tip of the iceberg is the minority of the individuals with AAT deficiency that have been clinically recognized, as I said, 4%, and the larger base of the iceberg represents the undiagnosed. So there's two populations of unknown proportions. Those who have severe deficient type, but have no signs or symptoms. And we have the highly symptomatic ones that carry a diagnosis of asthma, COPD, or liver disease, and have Alpha-1 antitrypsin. I think we probably see some of these patients. If you think this is unique to the US, it's not for us underdiagnosing and underrecognizing. You can see in this data that's pooled from a bunch of different countries that this is an international problem. You can see that in aggregate, it is a small minority, less than 1% of cases are diagnosed. And the highest percent right here in Sweden, in fact, where the condition was first recognized in 1963, but it's still less than 3%. So under-recognition is regrettably an important challenge. So Dr. Stoller at Cleveland Clinic performed a survey, sent out a survey to about 850 AAT severe deficient individuals. He got about a response of about 50%, of whom 304 reported severe deficiency, the PiZZ type. The mean age was 48 years. Mean age of onset of lung symptoms was 35 years old. The mean interval between first lung symptom and first diagnosis of AAT deficiency was about 7 years. And you can see the number of doctors seen until first diagnosis of AAT deficiency. So on the first visit, about a fourth of the doctors got the diagnosis right the first time. And you can see as many as 6 to 10 doctors, and the majority following at least 3 doctors seen before having a diagnosis. I would like to say that the diagnostic delay interval is decreasing with time, and that we're getting better at recognizing this condition, but that is not the case. Stoller did another study in 2005 where the vertical axis, we have the mean number of years between first symptom and first recognition, the diagnostic delay interval, which we have been talking about. If we were getting better, the diagnostic delay interval would be moving down. But as you can see, we can easily appreciate that this curve is horizontal, if not worrisomely increasing. There's been multiple studies that confirm that this diagnostic delay. The first study in 1995 by Stoller, and the most recent study in 2013 shows that the diagnostic delay is about 6 to 7 years. Again, a reminder that these patients are in our midst, but we aren't recognizing them. So why are we under recognizing these patients? Inadequate knowledge about alpha-1 antitrypsin deficiency. Stoller did a study with the residents at Cleveland Clinic, and they showed that IM residents scored only 63% on a 10-question quiz regarding diagnostic features of AATD. And there was no evidence of training effect. Senior residents scored no higher than the interns. There was a very interesting study done by Gerlich in 2013, where he surveyed German and Italian internists, general practitioners, and pulmonologists. And 1/4 to 1/2 of them, depending on the specialty and country, stated that they knew either very little or nothing at all about alpha-1 antitrypsin deficiency. In addition, 7 to 8% agreed with the statement, there is no treatment available for this disease. Inattention to guidelines, so non-adoption of clinical guidelines, has been widely recognized in medicine and is evident in the failure to implement various recommended practices, such as like low stress ventilation for ARDS, prophylaxis against DVTs. And then there's the therapeutic nihilism belief that making the diagnosis, we don't have a therapeutic option for these patients. And I'll change your guys' mind on that. That's not true. But there is a glimmer of good news. Campos did a study where he reported the trends in diagnostic testing of AAT deficiency. In year over year, you can see that the numbers are growing on the people that we are testing. So from 2007 to 2010, we've actually doubled. In recognizing 4,690 severely deficient individuals is important because, again, the treatment options for these patients. So there's been, in an attempt to increase the detection rate, a variety of strategies have been explored in the past, and new approaches are emerging as we have advances in technology. These include targeted detection in patients with COPD or unexplained chronic liver disease, testing of family members of affected individuals, newborn screening, EMR record data mining, and direct-to-consumer testing. Some of these strategies are already included in clinical practice guidelines, while others remain to be validated and implemented. There are some studies that I've found that had nurses and some other allied healthcare professionals like RTs that were providing help identifying AAT. In particular, there was a study done at Cleveland Clinic where RTs were testing all patients in the PFT lab that had evidence of fixed airflow obstruction. They tested around 3,100 patients, and they found 20 patients to have the severe PI-Z type. So I thought that was an interesting study that was done. Now we're going to go into the physiology of alpha-1 antitrypsin and the pathophysiology of the deficiency state. This is alpha-1 antitrypsin is a glycoprotein that is produced primarily in the liver. The protein is made in the hepatocytes and secreted into the bloodstream. It perfuses various organs, including the lung, and provides protection at the level of the lung parenchyma against neutrophil elastase. Neutrophil elastase being a threat to the integrity of elastin, which lives in the lung interstitium and provides some of the structural integrity of the lung that the lung depends on. This glycoprotein is translocated to the rough endoplasmic reticulum. It's glycosylated, transferred to the Golgi apparatus, and secreted into the bloodstream, where again it circulates and again at the lung level produces or provides protection against neutrophil elastase. Neutrophil elastase being a proteolytic enzyme that derives from the primary granules of our polymorphic leukocytes. The normal levels, which is a useful tool in diagnosis of deficiency, they vary from lab to lab. They use a special type of testing that's called nephelometry. It is in the serum, it's 20 to 53 micromolars, or 100 to 220 milligrams per deciliter. And you can see in the interstitium, it's 10 to 40 micromolars. In the epithelial lining fluid, it is 2 to 5 micromolars. We'll come back to these values when we talk about the protective threshold value. The structure of the AAT molecule, it's a single chain 394 amino acid glycoprotein. It has 3 carbohydrate side chains at asparagine residues. This is responsible for the folding and clearance. It has 9 helices and 3 pleated sheets. The green strand here is the active site of the protein. This is where the neutrophil elastase binds alpha-1 antitrypsin and cleaves that active site. I have a nice schematic of this on the next slide. Its serum half-life is around 3 to 5 days. So a major physiologic function of this molecule is to bind the neutrophil elastase, which it does avidly in a mousetrap-like mechanism. On the active side of the alpha-1 antitrypsin molecule captures the neutrophil elastase, and it is cleaved to releasing steric energy in the molecule, catapulting the neutrophil elastase to the opposite side of the alpha-1 antitrypsin molecule and inactivating it. We'll go over the genetics. It is an autosomal codominant inheritance. The PI stands for protease inhibitor. That's the nomenclature, and you have the PI with the asterisk allele. For example, you have the PIZZ type and the PIMZ type. You have the serpina gene, which codes for alpha-1 antitrypsin. It is located on the long arm of the 14th chromosome and has more than 150 alleles of this gene have been identified to date. The normal allele is denoted as the M allele, and it's the normal variant. It has 95% of the US population. And the allele most commonly associated with severe deficiency is denoted as Z, and it's found in 95% with clinically recognized alpha-1 antitrypsin deficiency. Again, people who are homozygous for the M allele are normal, and they're called PIMM, and those who are homozygous for the Z allele are PIZZ, and that's the severe deficient type. And again, more than 90% of the patients with severe are PIZZ. There's also an S allele and a null allele. They kind of came up with the name of these alleles based on the position of migration within an isoelectric field of a pH of 4 to 5. M meant middle, and Z was close to the pH of N. So that's, it was actually the lysine for glutamic acid position for the Z allele. And this is just a nice picture of the inheritance patterns. I'm not going to go over this in depth. So the abnormal folding and polymerization of alpha-1 antitrypsin. Again, the Z allele has a single amino acid substitution. You have glutamic acid to lysine at position 342, which results in abnormal folding and formation of polymers of the Z molecule within hepatocytes. I have a picture of this on the next slide. With alpha-1 antitrypsin, this trapped as a Z molecule polymers in the liver. The amount in the bloodstream falls, and there is a consequent decrease in the amount available in the lung to oppose the proteolytic function of neutrophil elastase, especially in people who smoke or work in dusty environments. And then this is an image, a histological study of the liver biopsy specimen from a patient with the ZZ alpha-1 antitrypsin deficiency. You can see the arrow here showing the eosinophilic inclusion bodies, which is unsecreted Z-type alpha-1 antitrypsin. This is highly suggestive, although not pathognomonic for alpha-1 antitrypsin if you got this on a liver biopsy. So we're going to move on to a very important topic, which is the concept of a protective threshold serum value for alpha-1 antitrypsin deficiency. It's very important to diagnosing individuals. The concept has emerged that one needs about 11 micromolar or serum level of 57 milligrams per deciliter to minimize increased risk of excess emphysema in such individuals. You have the phenotype on the left with the emphysema risk on the right, and the serum levels in micromolar and milligrams per deciliter in the middle. As you can see, the individuals have serum levels greater than the threshold, as well as the PIMZ individuals have serum levels greater than the threshold, and you can see that they have no increased risk for emphysema. Individuals, however, that are double heterozygotes, the S and Z, have serum levels that straddle that 11 micromolar or the 57 milligrams per deciliter value. Those individuals as a population, particularly if they smoke, are in fact at increased risk for developing emphysema. The risk is even greater for individuals that are ZZ type. As you can see, they have serum levels that all fall below the level of 57 or 11. And the null type have 0 as a result of translation problem or nonsense mutation that prevents translation of Alpha-1 antitrypsin completely. These individuals are, fortunately, it's very uncommon, but they're at very high risk for developing emphysema. Again, proposed protective threshold, 11 micromolars and 57 milligrams per deciliters. Important numbers to remember. So this is just, again, you can see the correlation on the vertical axis between the serum levels in micromolars and between the phenotypes on the horizontal axis. Normal on the left, you can see all their levels are above that threshold line. And then you have the ZZ, which are the severely deficient on the right. You can see that the ZZ individuals all cluster below that protective threshold value. These patients right here are important because they straddle that line and are at risk for developing the emphysema. So the clinical features of individuals with Alpha-1 antitrypsin deficiency. So in thinking about the clinical manifestations of AAT deficiency, it's really framed by 3 or 4 major clinical manifestations, the first of which is COPD, which may present as either emphysema, chronic bronchitis, or bronchiectasis. This, again, is resulting from the loss of the proteolytic protection of the lung by Alpha-1 antitrypsin, which is a toxic loss of function. The second major manifestation is that of chronic liver disease, cirrhosis, fibrosis, chronic hepatitis, or even an increased risk of hepatoma or hepatocellular carcinoma, which result from abnormal accumulation of Alpha-1 antitrypsin within the hepatocytes, which is a toxic gain of function. An uncommon but clearly related manifestation is that of paniculitis, which is the inflammatory condition of the skin. You have painful nodular lesions that migrate with time. And lastly, one that I was unaware of is a fascinating association with Cianca vasculitis, Wegener's, which I thought was an interesting finding. So here's the clinical spectrum of AAT deficiency. This was a study done by Larson, and he basically characterized 246 individuals that were severely deficient, and these are their presenting type symptoms. As you can see, COPD is a higher percent, around 75%, with liver disease being around 12%, with emphysema and chronic bronchitis being about equal. So the NHLBI registry that I mentioned earlier in the lecture really aimed to distinguish between patients with Alpha-1 antitrypsin deficiency from those with usual COPD without Alpha-1 antitrypsin deficiency before this study. So this is a multi-center longitudinal study with 37 centers participating in the registry, followed patients for 7 years. It was around 1,100 patients, all with the PIZZ or PIZ null type with severe deficiency. This evaluated the natural history of AAT deficiency in those receiving versus not receiving IV augmentation therapy. So you can see that it's pretty much equal between males and females. Again, this is an autosomal codominant disease, so one would expect an equal gender distribution. And it's high among people of Scandinavian descent, which would explain the predominance of Caucasian people. When you look at the age distribution, you can see that the registry eligibility criteria, that the youngest was 18 and the oldest was 82. The mean age was 46. They also included information on employment in the registry. And it showed that 30%, I don't have a slide on this, that 30% of the patients in the mean age group of 46 were retired, which goes to show how medically debilitating Alpha-1 can be. Here from the registry is the distribution of phenotypes, and the take-home message is that the vast majority of individuals that are severely deficient are of the ZZ phenotype, as 992 of around 1,100 or ZZ type. There's a variety of different allelic variations. In total, there were 14 different allelic variations that they were studied in this, but you can see that ZZ accounted for 95%, and therefore the most significant to recognize. The pulmonary function tests of these patients were consistent with emphysema in most of the patients in the registry. The mean post-bronchodilator pulmonary function values were an FEV1 of 42.5% of predicted, a ratio of FEV1 to FVC of 42.9%, with a mean diffusing capacity of 50.4 predicted. Like many patients with usual COPD, 60% of the registry of the patients demonstrated a component of airway reactivity with significant reversal of airflow obstruction over 3 spirometries after receiving a dose of an inhaled bronchodilator. Moreover, 78% or 78 patients had normal lung function. This is just a schematic of what I just discussed. The symptoms also resembled those in patients with usual emphysema and chronic bronchitis, or both. On enrollment into the registry, 84% of the patients had shortness of breath on exertion. 76% of the patients had wheezing with upper respiratory infections, and 65 had wheezing without respiratory infection. 67 had recent debilitating chest illness. 42% had usual cough, and 50% had annual cough and phlegm episodes. It's very nondescript symptoms, very difficult to discriminate between these groups, hence the need for testing these individuals for Alpha-1. Just, it seems very much like our patients that we see in clinic every single day. This is an important slide. Smoking accelerates the onset of dyspnea in AAT deficient patients. Cigarette smoking is obviously a bad actor, but especially in Alpha-1 antitrypsin patients, where the cigarette smoke recruits neutrophils to the lung as an inflammatory insult. The neutrophils recruited to the lung disgorge their neutrophil elastase and therefore increase the proteolytic burden to the lung. And in the absence of antiprotease like Alpha-1 severe deficiency, this may accelerate the development of emphysema and symptoms of emphysema, for the most part, dyspnea. So if one looks at these various series of studies on PIZZ individuals, severely deficient individuals, that their onset of their shortness of breath, you can see that smokers' symptoms are accelerated, with the most extreme being a study done by Janus in 1985, showing a 19-year difference in the onset of symptoms. This is just a graph showing the FEV1% predicted by smoking in augmentation therapy history. We're not going to go over that for time's sake. The natural history of Alpha-1 antitrypsin deficiency, they did a 32-year follow-up on the Alpha-1 antitrypsin deficient individuals, part of one of those neonatal screening study follow-up that we discussed earlier in the presentation. So they asked, what is the status of 32-year-olds with severe deficiency of AAT who were identified at birth? It was the follow-up on the birth cohort where a majority of the individuals were severely deficient, and they compared it with 17 normal individuals. And the results of that, you can see that there are very few smokers. They were told about this at birth, so they were discouraged from smoking because they were counseled by their parents and others about the hazards of cigarette smoking in severe Alpha-1 antitrypsin deficiency. This shows the potential therapeutic impacts of making a diagnosis of AAT early. You can see that the lung function in all of these individuals were normal. But again, these patients were 32 years old. They also had normal CT scans, showing that the emphysema is unlikely to develop in the first 3 decades of life in non-smokers with severe Alpha-1 antitrypsin deficiency. It may, however, develop after. So the FEV1 slope values by smoking status, these are the available studies on this. The best information available regarding the rate of change of FEV1 over time comes from the NHLBI registry that I've been speaking about. Here, where those patients were followed for 7 years, they were able to plot a rate of change and decline of FEV1. All of us, of course, lose lung function annually as part of the normal aging process. Among men and women, that value is about 19 to 20 milliliters per year among normal non-smokers. But you can see that in the registry, individuals shown in the red box, among never smokers, the FEV1 rate of change per year was 67, which is 3 times faster than normal. And among ex-smokers, it's about the same. It was 54 mLs per year. It wasn't a statistically significant smaller value. But among current smokers, recognizing that cigarettes increase the inflammatory burden and therefore it is a bad actor, as we've discussed, the rate of FEV1 decline is 109 milliliters per year, 5 to 6 times higher than normal. Again, this validates the risk of cigarette smoking in these individuals. Again, this is not a disease only associated with significant morbidity, but also has mortality. And in a follow-up from Larson's series that we discussed earlier, when they followed the 246 individuals for 11 years, the overall mortality rate was 37%. Most of whom died from respiratory failure, from complications of COPD, and some patients dying from complications from cirrhosis. This is the overall mortality from the NHLBI registry. We look at months and time on the horizontal axis. The mortality rate was about 3% per year, which kind of agrees with the Larson data from prior. If we stratify survival from mortality on the vertical axis and time in months on the horizontal axis, you see the FEV1 less than 50%, which is the yellow line here, shown in yellow, showed a mortality rate of 36% in 3 years. That's quite a sober and worrisome prognosis for these patients. Whereas people with well-preserved lung function with an FEV1 greater than 50% described normal survival curve, as you can see in the pink, over a course of 5 years follow-up. Most of the individuals from the NHLBI registry died from complications from emphysema, around 72%, and with 10% dying from complications of cirrhosis. With the only excess cause of death matched with normal peers in the study was emphysema and cirrhosis, as would be expected by the pathophysiology that we discussed. There is an interesting series of studies by Tanish and colleagues that reviewed patients from the Swedish registry in non-smokers' cause of death. You can see that fewer of these individuals died from emphysema and more patients died of complications of cirrhosis, as compared to 72% in the registry, and in this study, 28% cirrhosis. The message is that even if one is a never smoker, the risk of advancing age and cirrhosis increases. So how do we make the diagnosis of AAT deficiency? So you want to first start with the clinical features of AAT deficiency. And these are patients that we see every day. Early onset emphysema in a should be trivial smoker, chest x-ray with basilar hyperlucency, but we'll go through some of the imaging findings as that's not always the case. A family history of emphysema and or liver disease. You can have hepatic history with pediatric hepatitis and or cirrhosis, unexplained cirrhosis in an adult, hepatoma, some of the more systemic findings with paniculitis and vasculitis. All of these individuals should be tested. Here's an example of the imaging findings. Although the classic teaching in like step 1 and step 2 and board exam is the lower lobe hyperlucency on plain films. If you relied on this, this would lead to significant underrecognition, as 36% of PIZZ patients have apical predominant emphysema on CT scan. And this was confirmed in a study. Again, here are the studies. The chest x-rays, they evaluated 165 PIZZ Alpha-1 patients, 15% were normal, only 20% showed the classic emphysema at the basis, and they did CTs on 102, 64% showed basilar predominance, and 36% had predominant apical disease, which I thought was interesting. Here are the ATS and ERS diagnostic testing guidelines. Type A, they recommend testing all symptomatic adults with emphysema or COPD, incompletely reversible asthma, And they test asymptomatic individuals with persistent obstruction on PFTs and identifiable risk factors, patients with an FEV1 less than 80 predicted an FEV-FVC less than 0.7. All individuals with unexplained liver disease and adults with necrotizing paniculitis. And to consider testing in adults with bronchiectasis of unknown source, adolescents with persistent airflow obstruction, asymptomatic individuals with persistent airflow obstruction and no identifiable risk factors, and adults with C-ANCA positive vasculitis. But for the most part, they recommend testing those patients too. So why test these people? Because it's inherited, it's an autosomal codominant disease. Family members of proband are at risk of having Alpha-1 antitrypsin deficiency and of developing associated disease. It can favorably affect smoking behaviors. Because of occupational dust exposure, it is associated with worsened clinical status in individuals with AATD. Detection could affect occupational choice, and there's specific therapy for AATD, and it is available and recommended for individuals with emphysema. And official society guidelines endorse testing, establishing a standard of care that warrants compliance. So the testing for Alpha-1 antitrypsin. It's the serum Alpha-1 antitrypsin level. It's most often done by nephelometry. Normal serum levels generally range from 100 to 220 milligrams per deciliter. You can also do phenotyping, which are usually performed by isoelectric focusing, which can identify different band patterns associated with different alleles. And then you can do genotyping, which involves determining which Alpha-1 antitrypsin alleles are present, most often using PCR testing, targeting the S and Z alleles, and occasionally set up to detect less common alleles such as F and I. You can also do gene sequencing to achieve accurate and definitive diagnosis. When typing in Alpha-1 into our EPIC system, we get the Alpha-1 antitrypsin quantitative, which will be the nephelometry, the serum level, and then they also offer phenotyping, but I think the genotyping is a send-out test. The Alpha-1 Foundation offers free home-based confidential testing kit through a research protocol between the University of Florida and the Medical University of South Carolina. It's called the Alpha-1 Coded Testing Study. Patients can receive a kit and Lancet at home, submit the dried blood spot specimen, and receive in the mail a confidential serum level and genotype. I thought this was kind of a cool thing that they do, and it's no cost to the user, and it's supported by the Alpha-1 Foundation. So the treatment of patients with severe deficiency and emphysema generally resembles that of patients with COPD, specifically smoking cessation, bronchodilators, occasionally ICSs, supplemental oxygen, preventative vaccinations, pulmonary rehab. Lung volume reduction surgery is not recommended. It is beneficial in our subset of COPD patients, but it is generally less effective in those with severe Alpha-1 antitrypsin deficiency. It's specifically because the magnitude of FEV1 increase and the duration of such a rise are lower than that of the COPD patients. And the most important is the augmentation therapy. The specific therapy for Alpha-1 currently involves weekly intravenous infusions of purified, pooled human plasma-derived Alpha-1 antitrypsin, and this is the so-called augmentation therapy. Drugs for IV augmentation therapy are marketed in the US and Europe by a different number of manufacturers. The cost of therapy is very high, with the mean annual out-of-pocket cost of all patients with Alpha-1 antitrypsin deficiency to be approximately $2,000. With annual costs of around $5,000 and $2,000 for IV therapy users and non-users, respectively. This is a lifelong therapy, and treatment is costly and is commonly used only to treat the most severe forms of Alpha-1 antitrypsin. That would be the PIZZ type and the PI null genotypes. IV therapy was approved in the United States based on its biochemical efficacy criteria, its ability to increase the serum and lung levels of AET above the protective threshold values of 57, and preserve the functional activity of infused Alpha-1 antitrypsin to neutralize that neutrophil elastase. And there's also clinical efficacy criteria, which I'll go over to prevent or slow the rate of decline in lung function, to enhance survival, functional status, and quality of life. Biochemically, as shown here, we know that it is biochemically efficacious. The patients you can see here are below the protective threshold at the start. This was a study published in the New England Journal of Medicine. When given 60 milligrams per kilogram once per week, the serum levels rose, as you can see here, above the protective threshold. They decline with a serum half-life of around 3 to 5 days. At the end of 7 days, you can see that most of the time they're above the protective threshold, and it has, as you can see later on, after more continuous infusions, they remain above that threshold. So augmentation therapy does raise the serum levels. It does preserve the functional activity of the protein. And when we look at the evidence in regard to clinical efficacy, the results are somewhat more controversial, but more supportive of the clinical efficacy. We have the 3 large observational studies on top, which the NHLBI registry, which we went over in depth. And then you have the randomized control trials that have addressed the efficacy of IV augmentation therapy. And although no single trial has been definitive, the weight of evidence shows that augmentation therapy can slow the progression of emphysema. Dirksen did a study showing that augmentation therapy was associated with a slower progression of emphysema as assessed by the rate of loss of lung density on CT scan. But these cohort studies showed that augmentation therapy experienced a slower rate of FE1 decline than non-recipients, especially in those with moderate airflow obstruction. In the NHLBI registry, augmentation therapy recipients experienced improved survival. But there may have been some cofactors, socioeconomic status that may have biased that finding. On the basis of the available evidence, sorry, let me see, get back here. In the randomized clinical control trials, the augmentation therapy recipients did not experience a slower rate of FEV1 decline, but a trend, depending on the analytic method, toward a slower rate of loss of lung density was evident. The RAPID trial also showed that augmentation therapy recipients experience a trend toward a slower rate of loss of CT density. So the conclusions regarding the clinical efficacy and augmentation therapy for AAT deficiency through the ATS and ERS guideline statements, they recognize that supportive evidence of efficacy comes from the concordant observational studies, but not from a randomized clinical trial. The task force does recommend IV augmentation therapy for individuals with established airflow obstruction from AAT deficiency. And that being the strongest evidence is for those with moderate airflow obstruction, which I'll go over in the next slide. The evidence showed that augmentation therapy confers benefit. It slowed the rate of FEV1 decline and decreased mortality. Was stronger in individuals with moderate airflow obstruction. They have FEV1 of 35 to 60% predicted than for those with severe airflow obstruction. Augmentation therapy is not currently recommended for individuals without emphysema, and benefits in individuals with severe, defined as a FEV less than 35%, or mild airflow obstruction are less clear. So new and emerging treatments for Alpha-1. On the left, we have interventions that decrease the inflammatory neutrophil elastase burden, that is smoking cessation, environmental intervention to limit exposures, vaccination, and early aggressive treatment of inflammation and infection. We have the biochemically and clinically approved current treatment with IV augmentation of purified pooled human plasma-derived alpha-1 antitrypsin that we just discussed. And in the future, with ongoing studies, which could be in a presentation in of itself, there's a lot of bright future ahead with gene therapy, gene correction therapy, anti-polymer drugs, this molecular chaperone, which is offering promise, iPS cells and oral elastase inhibitors and aerosolized alpha-1 antitrypsin. are all things that are currently being studied and offer hope for the future. So the key takeaways from this presentation, I know it's kind of a lot. I think I had 70 slides. Alpha-1 is common, but under-recognized. The mechanism of lung disease is the toxic loss of function, and the liver disease is the toxic gain of function. They differ. The concept of a protective threshold value of 57 has been useful in guiding diagnosis of individuals with Alpha-1. Alpha-1 antitrypsin deficiency may present with COPD, even in never smokers. The rate of FEV1 decline is accelerated several-fold among smokers with AAT deficiency. All symptomatic adults with fixed airflow obstruction should be tested for Alpha-1 antitrypsin deficiency. I think that was a little bit of a surprise to me since I've never ordered an Alpha-1 test since I've been at fellowship. So I'm going against guidelines. Radiographic features of Alpha-1 antitrypsin deficiency include a lower lobe predominance of emphysematous changes, 2/3 and a high prevalence of bronchiectasis, a minority of which is symptomatic. Augmentation therapy is the infusion of pooled human plasma-derived AAT, and that evidence suggests that augmentation therapy has efficacy both bioclinically and clinically. And that the future is bright for Alpha-1 antitrypsin deficiency with novel approaches to treating it that holds great promise. So that is the end of my presentation. I know it was kind of a lot to get through. I talked really fast, but thank you guys for listening. I want to thank Dr. Godfrey again for her help with resources and directing me during this presentation. Thank you. Any questions? Thank you. Not any more questions. I'm going to stop the share.